And we are now live, Senators.
Terrific, thank you. And this is Senate Health and Welfare, continuing on January 25th. We have the Commissioner of Health with us. And before we ask you to introduce yourself for the record, we're going to introduce ourselves because we do have new folks here.
Okay, yeah, Martine Bueller. Hi, I live in Burlington and I represent Chittenden Central. Nice to see you again.
Good morning, Gabe Weeks, representing Rutland County from Prague.
Gary Williams, Rutland County from Polk.
And Senator Hardy will be back in, and you know me, Senator Lyons. And we have two guests here. Did you want to introduce yourselves?
Oh, sure. My name is Allison Descathy. I'm from Danville, Vermont.
Sandy Ryder, I'm a physician from Lyndonville, Vermont.
Welcome to both of you. Glad you're here. So, did you want to introduce yourself for the record? And then we'll go ahead.
And I'm Commissioner Mark Levine, Department of Health, here to expand upon the very minimal orientation to the Department of Health I gave you previously and provide you with, I guess my presentation is in 4 components. It's sort of Public Health 101, just to sort of get on the same page. It's what is the health department? A little bit of like, remember COVID? Here's what's going on. And then most importantly, here's what sort of we are passionate about now and our vision for the future. So I'll just make this full screen. There. Are we good?
We are very good.
Visual-wise?
Terrific, thank you.
Okay, so and I do want to allow time for discussion, so I won't go super fast, but this will all fit.
Do you want interruptions or would you rather we just hold off?
I think we can divide the interruptions into the components of the talk.
Perfect.
So I'll come to an end at each component and if there's something at that point, fine. So the reason my job is one of the coolest jobs in state government is the fact that we have the best mission statement, which is protect and promote the best health for all Vermonters, and healthy Vermonters living in healthy communities is our vision. People so frequently conflate health and healthcare and public health and the healthcare system. So I always like to put up this time-honored 75-year-old definition from the World Health Organization of what is health. And I think you can read it for yourself, but it focuses on health and not on disease. Not that we don't have a lot of disease and pay attention to disease, but the goal is we should all enjoy health. Public health, on the other hand, has a very traditional definition, which is really to focus on epidemics like one we might have just had, environmental threats, and the biggest driver of healthcare costs, which is chronic disease. So the flip side of that is health promotion, preventing chronic disease. The more modern definition incorporates the fact that we can't do it ourselves. We need to go across state government, across society to really do this good work. And it's really how do we get this whole community we live in to have the conditions in which people can be healthy. And that views public health as a driver and a catalyst and a real innovator, but also a way to help collaborate and form intersectoral partnerships, because nothing happens if you just ask the health department to do it. Some of the things that might make that definition come to life, immunizations, screening for big ticket diseases like HIV, promoting healthy lifestyles, keeping our air and water supplies good so that we don't get sick from them, working on the maternal child health side of things, preventing substances and things like tobacco use, etc. So just a little bit of a spectrum of what public health does to communities, for communities. when people are asked, what do you think determines health? The first answer is usually, well, access to healthcare and high quality healthcare. But that's actually, as you'll see in this pie diagram, only 10%. The predominant drivers, if we ignore genetics, which we're kind of born with, are the lifestyle behaviors we choose to adopt, whether it's nutrition, whether it's activity, whether it's substances, etc., and the socioeconomic / environmental circumstances we find ourselves in, or that we may have been born into. So those are the core factors. This is a nice thing because it brings this home a little more. This is called the health impact pyramid. Things at the top with the lowest impact, things at the bottom with the broadest. As a practicing physician for decades, my life was spent mostly in the top 3 parts of this. So I did a lot of counseling, which is important, just like in public health, our messaging is important. But counseling doesn't always work overnight. I may tell someone about the health benefits of smoking cessation, but it might take them a decade before they finally do it. But it occurs, which is good. Clinical interventions means all the chronic diseases I've treated. And then long-lasting protective interventions are those things that doctors do to be preventive, whether it's scheduling you for your mammogram or your colonoscopy, or whether it's providing you with your flu shot, etc. The bottom 2 are really the most instructive. Changing the context, meaning making the default decision that an individual makes a healthy choice. So you can't buy a box of Nabisco crackers anymore that has trans fat because they'll kill you. So they don't market it that way anymore, and they use a lot of better fats. We've taken that choice away from you. You can't go into a restaurant now and die from secondhand smoke because we've taken that choice away from you in a sense. Some communities have chosen to fluoridate their waters, some have not. And depending on where you live, you may not have to worry about what to do about your teeth in terms of protecting them from cavities. So that's sort of changing the context. And there's always that delicate line public health and government walks between what we call a nanny state and a savvy state. And you can understand that, I think. And then the bottom is the most critical, the socioeconomic stuff, access to wealth versus poverty, food insecurity, housing insecurity, etc. Those are the problems that really drive, are you going to grow up healthy or not? So the principles in public health are focusing on the broader population and the health outcomes, focusing on a wellness task, focusing upstream, as we call it, to either improve upon risk factors that people have or avoid them at all, or enhance the likelihood of positive outcomes because there are protective factors already in place. And then that discussion automatically links to the social determinants of health, which is really the circumstances we all are born in and eventually die in, we grow up in, we live in, we work in, we go to school in, etc. And it's sort of the thing, it's not your genetic code that counts, it's your zip code. So when we talk about social determinants, obviously we're talking about, are you employed or not? Are you in poverty or not? Do you have housing security? Do you have food security? Do you have access to the educational resources that will advance you in life? Et cetera, et cetera, et cetera. All of the fundamental things that I talk about in this State House all the time, whether you're in a health committee or not. The furthest upstream one can go, and this has only been realized in recent years, is to provide everybody with the same fair and just opportunity to be healthy. Different than saying, well, you grew up in the right neighborhood or whatever, but health equity has to do with that opportunity. And usually when there is inequity, it's due to historical injustices, socioeconomic disadvantages, and always associated with these basic categories of race, gender or sexual orientation, disability status, you name it, socioeconomics. This is a pictorial presentation. The left side is equality. Everyone has the same support to stand upon, but you'll see it doesn't help everyone to see the game. The middle one is equity. You've given the level of support to each individual they need to see the game. And then the right side of this triptych, I guess we'll call it, is liberation, where you've removed the social or the obstruction, the barrier to people seeing it. That's health equity. So every few years, we do a state health assessment to ask ourselves, what do we know about the health of Vermonters? And we usually find that if you're not as healthy as the average Vermonter, it's because you fell into one of these groups that suffers from these injustices. We developed from that assessment a state health improvement plan, and we're due to start that process again in the near future. The pandemic kind of put us on a different timeline, as we know, but we have a state health improvement plan. We've learned that the 5 core areas that we should be focused on are child development, chronic disease, mental health, substance use, and oral health. But can't separate any of them from the right hand of the slide, which is the social determinants of health, the conditions people find themselves in. And so these are the populations in focus, which I described, that always show the disparities in the data and the inequities in real life. Morality is one that I've added on because it's unique to states like Vermont, where we actually have evidence that the more rural you live, the more you may actually have inequities present. So that's the first part of the talk, to orient you to my world of public health and the health department's world. So I'll stop there if there's any questions on that segment.
Questions? Okay, so we will have bills up there that really relate to some public health interests, and we'll have you back in.
Oh, I relish the opportunity.
Good, I know. So we're looking forward to it, actually.
And I'll tee some of that up at the end.
Okay, good. All right.
Good morning. Everything I just presented was about Public Health 101. You had that course already.
Awesome, thank you.
Now we're in the part about just the structure of the health department. These are all of our divisions, and I will go over them one by one. You'll notice they, again, are on a foundation of health equity, and we now have an Office of Health Equity Integration to add to the list. So environmental health, this committee and the legislature was very instrumental and led in school drinking water issue. We're always also involved in lead in housing. Cyanobacteria, fancy way of the blue-green algae, that's the same thing. And then climate change, big parts of what that division does. And I'm not going to tell you everything each division does, just give you a ballpark idea. Public health traditionally has been most focused on the maternal child end of the life cycle, not the aging end. But by the same token, this is a very critical end, and all the things that go wrong with people usually begin prior to birth or right at the time of birth, the circumstances they are born into. So we do a lot with pregnancy and breastfeeding. Vermont has we are so healthy, but we have very ugly statistics when it comes to the maternal use of substances, from nicotine all the way to opioids. So we spend a lot of time on that. School and adolescent health. Everyone is familiar with after-school programming that's so critical to helping adolescents in their idle time do the productive things in life and not the destructive things in life. And then our WIC programs, women, infants, and children nutrition programs, which you're familiar with. Laboratory sciences and infectious disease. I think you got exposed to a lot during a 3-year pandemic. But we also have plenty of other infectious agents that we deal with, and we're always dealing with vaccinations because the immunization registry is under that section, and there are more vaccines than just the COVID vaccine. And then the picture is of our public health lab. state-of-the-art facility in Colchester. Substance use you are very familiar with as well due to the opioid crisis, but of course they will tell you that we do more than opioids. There's cannabis, there's alcohol, you name it. Stimulants becoming more of an issue nowadays as well. Stigma, combating stigma is a big part of the division's work and a lot of our messaging campaigns as well. Health departments are very prevention focused, but the reality here is our health department substance use division is involved in every aspect: prevention, intervention, treatment, recovery, and making sure people have access to all of those services. The little balloons are the local health offices. Every region of the state has one. And in each local health office, there's a lot of efforts going on in the WIC program and vaccination programs. They're also the local connection to all of our partners and collaborators, the real boots on the ground, and they're critical to the really running of public health in Vermont. We have a centralized health department, but the district offices, though they are part of the central office in a sense and do what policies and other work comes down to them, they are really grassroots and bring so much up as well from their communities. So it's a really nice structure. We talked about chronic disease earlier, and health promotion and disease prevention is the division that's interested in not only help managing, often through self-management programs, these diseases, but helping prevention and health promotion. Most of our tobacco control work is in that division. I put healthy aging on the slide because it is traditionally an ignored part of public health. And part of my mission, makes it sound too high, is actually to work with our colleagues in Dale and across the state to really focus on healthy aging, because what helps an aged person be healthy helps everyone be healthy. You know, it's the rising tide lifts all boats or whatever. You also were exposed a lot to emergency preparedness and injury prevention because they were a part and parcel of the pandemic as well. But they also respond to all disasters, like even the snowstorm we had a couple of weeks ago. We have an unfortunately tiny injury prevention effort. Focuses on things like suicide, falls prevention, but the bottom line is most of what we can do in that is funded by the CDC, and they provide very little funding in that arena.
What difference would you make? Just, I know I'm supposed to wait till the end, but
Yeah.
maybe at the end you could talk about what you would do differently to.
Sure.
Yeah, okay.
Okay. Emergency preparedness, just did health statistics is just what it says. The health department runs on data. Everything we do, we try to make data driven when there is data available. Plus we have vital records and registries to take care of. And we measure our outcomes. So we have a dashboard, we have results-based accountability framework. We make sure that if we're going to say this is a problem in Vermont, this is what's being done, that we just track that and understand if we're actually being successful or if we're not. So that's the end of that section. With regard to injury prevention, so it took a big grant, a separate grant from CDC and others to the Department of Mental Health and to us to really rise level of attention to suicide. And now you've seen the results of that, the whole 988 thing, the Facing Suicide Vermont website, which is phenomenal. If you haven't looked at it, provides a lot of lived experience from people who have not succeeded and from family members, even of those who have succeeded, which I think provides just tremendous information for the public at large. And it's filled with resources and sort of self-help things. But we could do so much more in injury prevention, really. It's just something that's generally hard to do without a lot of funding. What we do in falls prevention is good work, but it needs to go further. Our falls rate in Vermont is another ugly statistic that we could improve on. A slight slice of COVID, just to put us on the page of where we are now and what we've learned. Because with a respiratory virus, this is the public health toolkit. You'll not notice anything on there that's like super high tech and dramatic and would like say, God, the next time this happens, we can pull on that thing out of the toolkit and we won't have to go through 3 years of what we've been through. But this is the toolkit. It does underestimate a little the value of contact tracing, so I just want to mention that again. Because for half the pandemic, contact tracing was a critical dimension of what we did. And then when the virus became so transmissible and you couldn't even notify anybody quick enough, it didn't play a huge role, and it was frankly a waste of human resources. But in that whole early phase, post-contact tracing was critical to the effort. Contact tracing, of course, takes access to testing and a good testing infrastructure. And it takes cooperative people who will do what you tell them to do in terms of isolating, quarantining, etc. We had both of those in Vermont, so it worked very well. But this is the toolkit. What I need to explain to people, and I give tons of talks on this all the time, although I think finally people are sick of hearing about it, is that the pandemic is actually not a pandemic. It really was several phases, and the response changes each time. And I think people were always thinking, well, why are we doing this anymore? We did it before, or why did they throw that away? Or why, so I just want to explain. Phase 1 was the beginning. Unknown virus, no testing, no PPE even, a lot of disasters, and a population that's very vulnerable, especially in Vermont, one of the oldest states demographically. So containment, meaning contact trace, test, isolate, quarantine those who are close contacts, had to be the primary strategy and worked tremendously well. We suppressed the virus like crazy. And people actually came out of that like, wow, that was great, thinking that the future was rosy and cheerful until we started to encounter variants. This virus has had an uncanny ability to continue to evolve. We're watching evolution real time. So phase 2 was the UK variant, which was the first real variant. And that's where people have gotten pretty comfortable going back to the stores and kind of trying to live their lives in some ways. But we developed pretty quickly in that variant data that said that travel, meaning even a Vermonter who had left the state and came back, but also visitors, and modest, not large, modest size household gatherings were where our cases predominantly were. And because we were doing contact tracing and interviewing and all that, we knew that very well. So that was our strategy, was to focus on those two things and let people realize you can still go to, Hannaford's and Costco and whatever. And it's not that kind of interaction that's going to put you as at high risk. Still have to be careful and use the rest of the stuff in the toolkit, but we don't have to like close down society again and say, stay home, stay safe. Phase 3 was Delta, which was even more transmissible. And I think, though the data is not coming out cleanly, but I think a more virulent part of the virus. But at that time, of course, we had a vaccine. So the vaccine was the primary strategy, and people said, all you talk about is the vaccine. We're sick of hearing about the vaccine, but we got the state vaccinated. Over 80% of people got their doses of vaccine, and that was powerful, very powerful. There were some things that we continued on in terms of recommendations. There were some things we didn't continue on in terms of mandates, and that's where controversies came in, as they will, and I'm completely fine with that because it all has to do with where people were in their own personal existence and where the governor and the governor's team felt the state was in its existence. And I'll get into that in a second. And then we came into the whole of last year, which was Omicron. Omicron meaning the march to endemicity. a less virulent than Delta, but certainly way more transmissible, and one that continues to evolve and develop subvariants all along the way as we speak in time. But at a time when people were sort of like, I'm not going back to what I did before. Not all people said that, but many people said that. So why are we in sort of the stance we're in now, where you even mentioned, chairperson, that we have masks, but we're not wearing them today, but the capacity level's going up, we're gonna put them on. And it's like, those are the kinds of things that really the population has adopted now to some extent. So we give recommendations, nothing's mandated. In fact, people are pulling mandates back by the Legion, like the military pulled their vaccine mandate back. New York City pulled back all kinds of mandates. They're trying to find that sweet spot between what people want and what government wants, and try to make everybody happy. It's really hard to do, believe me. But we have
What
now.
public health says.
Yes.
Yes.
Right, and so we have an up-to-date, vaccine. We're not seeing everybody take the bivalent booster, but we have it. We have Paxlovid and other treatments that are quite available. People know how to risk assess and understand what risk level they might tolerate. And they have access to all the things in the toolkit, including masks, for when they want to wear them, but they're not in circumstances where someone's mandating them. At least not government is not. But the last bullet is the most important. It doesn't mean we're blowing off the fact that COVID is still here and that it could hurt somebody. And that's where it becomes very challenging, because yes, you get COVID, it's disruptive. You may not get super sick, or you may, but you may be out 5 days that you didn't plan on being out 5 days. You may still get long COVID. There's evidence that that's continuing. And what is that going to mean to you in your life? And then many people, they don't lose their vulnerability over time. They're either still older or they still have other diseases. But some of them, appropriately, I think, feel that they've been thrown under the bus because the rest of society isn't really looking out for them, because they're not masking in front of them and this and that. And that's very challenging, and I can just put that on the table for everybody. So today, bivalent vaccine, subvariants continue to develop. We're now in the XBB variation coming up. Therapeutics aren't working as well. The Paxlovid is still fine, thank God, but the monoclonal antibodies, there is no monoclonal antibody to use anymore. We use the CDC community levels to give people a sense, as you referred to earlier, is it green, is it yellow, is it orange? We still have the toolkit and can recommend many things for when your community level evolves from one color to another. And we are in a situation where COVID is actually not the thing that's breaking the healthcare system. It's RSV, which now, thank God, has come down. We almost ran out of pediatric ICU capacity, but didn't. It's the flu. We almost ran out of adult ICU capacity, but didn't. And COVID is just a sort of steady level that isn't breaking the healthcare system. And then most importantly, lots of other diseases are breaking the healthcare system, which we'll get into. So I just wanted to introduce you to the fact that a lot of the decision-making that happens in public health, I'd like to call evidence-based public health practice, but if you look at the definition, it's quite broad. Integrating science-based interventions with community preferences to improve the health of populations. So it's not quite the nanny-savvy state we talked about earlier, but it is really trying to say, are we at the point where we should do something by a public health standard that's going to very much interfere with the way communities and lives function traditionally, or not? And I want to impress upon you, it's not isolated to COVID, it's public health. So looking at the bottom, if you're in a community that fluoridates, well, you're not going to have things applied to your teeth and stuff because you're drinking the fluoridated water every day. But if you're not, you may have a community that's actually very much mired and meshed in controversy about fluoridating their water. The public health recommendation is do it, but the community's level of attentiveness to that is what's going to drive it. The whole opioid use disorder discussion. We are in a very enlightened state that says, if you have a syringe service program that allows someone to exchange needles, you don't have the same problem as other places might have with hepatitis transmission, HIV transmission through dirty needles, and the stigma associated with substance use disorder. So more people may die because you didn't allow them to have access to those facilities. And then finally, the bottom one is really tobacco related, but it is the way we succeeded in Vermont. This legislature and the governor and public health all came together and said, we don't want our youth dying of traditional things from tobacco, combustible tobacco, nor do we want them vaping and setting them on the wrong track by doing that. And so we created a bunch of policies that would prevent that. This slide isn't so much important. And then the last thing is just, when we did get to the point of like, can we still tell people they must do this, they must do that? When we said it's time to not tell them must do this, must do that, it was because of these competing priorities, which are the ones that we're addressing right in this state capital every day. Mental health crisis, the suicide crisis, substance use crisis, social isolation, which is the driving force for all evil in public health. Education setbacks of our youth. The tests are showing that every time that they're done. And how do we help our youth recover from that, not only intellectual setback, but the emotional and social setbacks as well. And then I provided the definition of health debt because it's really the negative lifestyle behavior choices many people made during the pandemic when they were home and isolated and couldn't live their normal lives that actually have led to why our emergency departments are so full right now. They're full of people who have mental health issues, substance use issues, and chronic diseases that either came to light during the pandemic because of these behaviors, or that were exacerbated, or that people just didn't tend to because they were afraid to go to the healthcare system during the pandemic. So we're seeing the downstream effect of that. So that's the end of that part of the talk. And the last part is my priorities. So if there's any questions on COVID, I'll be more
This
than
is
willing to
helpful.
help.
Thank you. It's very good. Questions?
Okay, so let's
Let's
just,
keep going, because,
and I'm keeping this high level so we can
Okay.
have discussion about it.
okay,
So even though I told you I've really tried to move the health department in the aging direction for healthy aging, it's not because we threw away the baby with the bathwater, so to speak. We're still very, very focused on early childhood and strengthening families and building resilience, because that is where it all starts. There's going to be a report coming out today about domestic violence,
Mhm.
which is going to be absolutely horrible, I'm sure.
Yeah.
And I would posit that it's what circumstances people grow up in that determines so much of that.
Yeah.
This committee is probably familiar with ACEs, adverse childhood experience, etc. Now they call them APEs, adverse family experiences, but the whole thing is you've got to focus on this part of life if you want to make substantial change. So the priorities in the tobacco world really did that. Preserving kids' brains is what I'm all about. So the lead in the drinking water, thank you, that's all about that. The trio of laws combating vaping, thank you, we're all about that. Toxic stress, the Substance Misuse Prevention Council is all about that.
We're going to have David Englander come in on Friday
Yes.
talking about that.
Yes,
That's great, yeah.
to introduce you to that. And then the recovery from COVID. This whole business about preventing ACEs and building resilience, we have evidence-based nurse practitioner-led home visiting programs that are very successful at the time of birth through 6 months. at really, I call it working on the dyad of the mother or family with the new child. So they identify issues in the new child, but so often their power is identifying issues at the mother or family level, whether that's depression, whether that's substance misuse, whether that's trouble with breastfeeding, whether it's with any of the social determinants of health we talked about. Connecting people to those services is really critical at that juncture. So in the governor's budget address, you saw a work on expansion of the blueprint, and involved in that is this thing called DULCE, which is, I won't go into what the letters mean because they make no sense, but it's a program that embeds a family specialist in a pediatric office. 95+% of our newborns are in a pediatrics office. It's an extraordinary number. So they can be exposed to that specialist, and if there's issues going on, what better place to address them there? And we have piloted that previously in 5 locations in Vermont. It works tremendously, so we want to spread it through the state. So that's the focus of that. Next set of priorities has to do, of course, the opioid crisis and substance misuse, which you'll learn about the Prevention Council and its work. There's the Opioid Settlement Advisory Committee, which Senator Hardy is quite familiar with now, which will come out with recommendations in a timely way so they can be moved up through the process, so to speak. Again, there's so much that needs to happen here. There's so much that is happening, but we need to continue to be innovative and creative without going too far out in terms of something isn't really well researched or evidence-based yet. We need to call it for what it is, but there's enough things that people are still dying. We have to do something very active. This is sort of the charges of the council. I won't steal David Englander's thunder on Friday, but these are just the 3 things. You can just read them quickly about improving protective factors, decreasing risk factors, and what those prevention efforts are. And then this is just a laundry list, but they're all related. They're all sort of the fallout from the pandemic, but to be honest, this slide could have been made, and I think I may have made it before the pandemic, because they don't disappear, all right? The only word that is newest now is that integration work. So there is a mental health integration council. Our report's due out in July. And some really good stuff is going to come out of there, because mental health has so often and for so long been marginalized, maybe the right word. It's not considered part of a holistic approach to healthcare, and it needs to be. So integrating that much better at the primary care level is really a focus for that. Integrating substance use disorder and mental health together is a big focus as well. We've already talked about suicide prevention, which remains a priority. Healthy aging, which you won't see a lot on that, but it will have its time. And then the health promotion stuff at the bottom, unfortunately, there's only so much money to go around to do so many things, and there's only so many crises that are recognized now and are exacerbated. So I'll be very honest, it's not getting its due in terms of attention or proposals for funding, and it's just really challenging. The last time we actually did anything in that was Rise Vermont, which you may or may not remember. And Rise Vermont got sort of integrated into the ACO, OneCare, and now it's sort of defunct. And that's unfortunate. The work Rise Vermont did and that the health department partnered with it on continues at community levels, and that's in the 3-4-50 arena. So for those who are new to the committee, 3-4-50 is the 3 healthcare behaviors that are adverse, so poor nutrition, poor physical activity, use of tobacco, that lead to the 4 leading causes of death in Vermont from chronic disease, which are cardiovascular, which includes stroke and heart, lung disease, diabetes, and cancer, and that number of deaths exceeds 50%, which is like 58% of the deaths in the state are from those 4 things. So all the work in 3450 is a little bit below the radar, but it's partnering with schools, workplaces, and community planners and redesigning all of the work they do. And it actually does really
actually
good
has a
things.
great grandmother
Yes,
with champs.
yes,
So, yeah,
right.
it continues to be under the radar.
It's under the radar, but it has an impact because it impacts what goes on at the work site in terms of work site wellness activities,
Sure.
what goes on in our schools and their lunch programs and all of that, and how communities actually figure out that public health is part of what their planning needs to be.
And
So,
it's the question that I'll ask you to talk about later, maybe
Yeah.
After you're finished with this
or
section.
I'm only a slide away. So.
Okay, we'll keep going and
Yeah,
I'll ask
we'll
it.
just- Environmental health, I mentioned, we're focused on the lead still, but that's a success story. We're focused on PCBs now, which is a new story. It's rolling out much slower than anybody anticipated because from the Department of Environmental Conservation vantage point, there are not enough consultants and the consultants are very slow. And the processing of the test has been slow, et cetera. Fortunately, we're not finding disasters, but we don't have big enough denominator yet to say that with confidence. But that's okay. And of course, we're playing a big role in climate and health, but you don't really hear about public health much with climate initiatives. But obviously, all the work on electric cars and on decreasing emissions and stuff is public health work. And we call out all the downstream impacts of what climate change has done, which we don't have time to talk about today, but it's an important topic. The last slide is, again, to just reinforce how public health works. It's very illustrative. So on the left side, this is our state health improvement plan strategies. Investing in policies and infrastructure that create healthy communities. That means educating communities about fluoridation and how to do it if they are willing to do it. That means weatherization, which is a big cost item now in the budget, and housing, of course, because those social determinants determine everything. And then doing the things 3450 does. The middle column is everything I've talked about with maternal child health, with home visiting programs, Dulce, and really working with communities to allow kids to grow up healthy and to allow people to have resilience because they're also slammed by the mental health aspects of what's happened in the last couple of years. And then the right side is sort of our community / clinical / public health integration. So you'll see at the top, integrating mental health, substance use, future aspiration, oral health into primary care. We can't slam them too much right now because primary care is very beleaguered right now.
Totally.
And having been a part of that community, I'm not going to be the one that slams them with too much. But we'll start with the mental health integration for sure. Another thing on that side is integrating oral health into healthcare practice. Doesn't mean just practices, but what nursing homes do, school programs, we do a lot of that actively. The one above it, implementing screening, brief intervention, and navigation services for health behaviors and for the social determinants. That's what the Dulce program is. That's the whole intent of that part of the governor's proposal. And then at the bottom, of course, is all the things that take much time because they deal with health equity. So you don't take literally generations or in some cases centuries of historical injustice and devise a strategy and it's over in the next year. That is much more slower moving, but you start paying attention to it now. And as we like to say, you apply a health equity lens, no matter what you're talking about, so that it never gets forgotten about. And it's a core part of your decision. That's the end of my, contact David if you have any questions. So that's my presentation. Still leaves
I
us
think
more
he'll be
time.
thrilled with that.
Leaves us time for questions.
Terrific. No, thank you. I mean, this has been a terrific overview of what's there in Department of Health. And obviously, we're going to have bills up on the wall that will bring the department back in and conversations that are really, really important. So
You said there was one question,
I did,
yeah, I took it out.
yeah, I have a couple questions, but I can save them for another time when we're looking at the prevention council or other.
Okay,
There's one burning question that I always have, and that is, we talk so much now, we're finally talking about prevention, and we're actually doing something about it, we're investing in it. And are we measuring our outcomes to understand what the savings are for all the pathologies that we're avoiding down the road?
yeah, so let's use,
Do we have a dollar sign to go with?
Yes.
I know we're saving people's lives, but do we have a dollar sign to go with?
so before we even put the blueprint on the governor's proposal set
Mhm.
and convinced him, we talked about return on investment of the blueprint itself and why further expansion of that should bring similar returns. But for an example, closer to heart, everyone last year came to an agreement that $3 million would go into prevention regarding the opioid crisis. And it was specifically dedicated to what we call prevention coalitions at the community level. We have communities that have had these for a couple decades and shown wonderful success in reducing youth uptake of nicotine, cannabis, and alcohol. And we have data that shows that the years that the grant money was fine, they succeeded. And if there were years that the grant money disappeared, the statistics went the wrong way and only returned to better when they got the money back. So we have return on investment from those experiences, which I think allowed people more readily to say, let's send $3 million that way, because there is an equity right now, inequity with regard to who in Vermont can benefit from these coalitions and the school-based programs as well. So the goal was to spread that much more generously everywhere.
Okay, and at some point, I know I always ask this question. So if you have smoking cessation programs and you avoid cardiovascular disease,
Yes.
what are your savings? So
Yes.
we've gotten some of that, but it's not as powerful.
Yeah, we should bring that back.
It's never as powerful. Yeah. Go ahead.
Just really quickly, a follow up on what you were just saying about the prevention as it relates
Yes.
to substance use disorder. We had the chief prevention officer, is that her
Yeah,
title?
Monica. Yeah.
Monica in here, and she didn't seem to be aware of the funding that is available for prevention when it comes to substance use. So if she hasn't already reached out to you, you guys should get together,
Yes.
because I mentioned to her the presentation you gave at the opioid settlement,
Yeah.
and she should see that.
Yes, yes. And she's on the Substance Misuse Council. so
Right.
Yeah.
She will.
And I think she did talk with David about getting that information, so we should ask. her.
Yeah,
Yeah.
just wanted to close
She's
that.
actually on the phone with me at
Right now,
2:00 today.
2:00, we'll mention her.
Yeah,
to her.
we're at a
There you
regular
go.
meeting, so
Yeah.
I can introduce that.
Okay.
This is terrific.
Anyone else?
Any other questions?
It's not a question, but it's an ask.
That's a question.
Yeah, three of us sit on the education committee and we're taking a deep dive into the state of our school buildings around the state. I was happy to see that you discussed that on one of your slides. PCBs obviously are an issue, but they're not the only issue, and I know you know that. Everything from poor air quality to actually like dangerous physical structures, as well as lack of ADA compliance, not to mention radon and lead and all kinds of other things. So when as we do the work of trying to make some statewide improvements to these really, really critical structures that you know how important they are, it would be great if you could weigh in and discuss from your public health lens how important that will be.
Yes, no, and public health, often below the radar, partners with the schools a lot. So when it comes to radon, testing programs and mitigation, when it comes to asbestos, testing programs and mitigation, lead, of course, you name it. So some of the things we can only recommend and provide resources. Other things are actually written into statute and whatever, and it's a lot different kind of work then.
Even things like lighting, they
Yeah.
really make a difference. too.
And you mentioned ventilation, that became the catchword from the pandemic, but do people really understand what that means? And when can you feel good about the ventilation changes that were made, or feel good about the situation you're in, even if no changes were made because somebody did an assessment? There's a lot of smoke mirrors around that. So it's challenging, but schools have paid attention to it for sure. But it's hard to tell kids in school, leave the window open in January, have an outside class in January,
But they did it during the
They
pandemic.
did it,
Yeah,
yeah.
they
So
sure
I
did.
mean, these are challenges, but they can be met.
So I did remember a quick question, but you don't have to answer it. It's just, maybe it's more of a comment, how important it is to ensure that our kids get 30 minutes of physical activity every single day at school, and they're not getting it. I don't know whether you engage,
That's part of 3450,
yeah.
and what we do when we engage with the schools, for sure.
It's a tough,
It's a tough one. Secretary French and I talk all the time. I can find out if there's a path forward on that.
that would be great.
Yeah.
I know for a time, years ago, I worked with some of the school folks on the curriculum development and all of this whole big area, and that was a big discussion, and some schools they didn't have the time.
Right.
Don't we hear about that in our own personal lives, right? We don't have time.
Exactly.
Mhm, yeah.
Exactly.
So we have to, I guess if we learn that behavior early on, maybe we will have time.
Right. Part of it is letting people understand what their options are and
Yeah.
how to build things into their lives that they didn't really consider before.
Well, I think it's time. Thank you very much,
Yes.
and we'll go offline now, and we'll call it a wrap for the day. Appreciate everything and everyone here this morning.